Uh, why I choose this? Because I feel that in different kinds of cardiovascular disease, the management of hypertension might differ. It differs according to the age, it differs as based on the target you want to reach to, and it varies as which medication to start and what kind of plans you are having in these particular patients. And my talk will be about management of hypertension in cases of stable angina, in cases of acute coronary syndrome, in cases of heart failure of ischemic origin, in cases of atrial fibrillation, valvular heart disease, cerebrovascular disease. That will be the talk. And I'd like to thank Dr. Basata for squeezing me today because I'm traveling tomorrow, and this is practical things. There is nothing new in my data, but it's practical things that we can go through it one by one. Hypertension, as you know, represents a significant burden on health care. It is responsible for 62% of stroke and maybe 50% of heart attack. How can they? If you can see that 25% of the population, they have hypertension. And in people above the age of 65, maybe 50% of the population are hypertensive. The global mortality shows the impact of hypertension as the #1 cause of global mortality more than anything else, more than tobacco or high cholesterol. And you can see that hypertension can progress to cardiovascular disease, and it can end up in myocardial infarction, in heart failure and death. And that's why we'll be very careful when we look at the markers of the disease progression, the albuminuria, the LAD, LVH, CRB, etc., because the disease we can prevent progression of the disease in the early stages. Well, I believe that hypertension causes cardiovascular disease by two ways: either a direct effect through physical forces, hemodynamic, endothelial injury, or it could be due to unassociated factors, either sympathetic nervous system, RAS system, a decrease in release and activity of vasodilator, and most important, in the presence of other risk factors. You can see here hypertension can end up in coronary artery disease either through endothelial injury, atherosclerosis, coronary artery disease, or through increased load on the ventricle, left ventricular hypertrophy, and so there is a mismatch between the myocardial need and the available blood. And there is a causal relationship with every 20/10% increase in blood pressure, there is doubling of the cardiovascular mortality. And the good news is with 5 millimeter mercury reduction, there is reduction in stroke and coronary artery disease. And as simple as 2 millimeter mercury decrease in the mean blood pressure, you can achieve 7% reduction in the risk of ischemic heart disease mortality. What about associated risk factors? There is a strong interaction between hypertension and other cardiovascular disease, namely hypercholesterolemia, diabetes, and mellitus, and smoking. And you are all familiar with these diagrams when you see that high blood pressure, if you have if we plot the age on one side, there is no mark, if you can have a pointer. There is blood pressures, and down you can see the hypercholesterolemia, and whether the patient is a smoker or not, you see that hypertension in association with risk factors end up with a high score, whether in high cardiovascular disease risk country or low cardiovascular disease risk factor. Even the relative risk, 10 years cardiovascular mortality, is a function of hypertension in association with risk factors. And when we talk about risk, can I have a pointer? I want to stress on a point that if you look at the patient at 60 years, where he is having low cholesterol and normal blood pressure and he is non-smoker, the 3% risk is similar to someone else who is 40 years old, but he smokes and he has high cholesterol and high blood pressure. So what is important to us is the physiological age, not the chronological age, because you can be 60 years, but you are 40 in terms of risk. So let us go one by one. Management of hypertension patient with established coronary disease. Until 2014, everything is not. Until 2014, in the guideline, there was no mention on management of coronary heart disease. But 2015, there was a statement on how to treat hypertension in patients with coronary heart disease. And in this case, and in year 2017, there was a specification. There are things that relate to the age-related issues, which is important because most of our patients are old. And what kind of target blood pressure, and what's the efficacy and favorable role in secondary prevention of stable ischemic heart disease, acute coronary syndrome, and heart failure. Age. Below the age of 50, the diastolic blood pressure is the most important thing, and above it is 60. Above 60, it's systolic hypertension. Give me another one, please. It's hard. It's important in elderly. You lower the blood pressure slowly, like the frog. You have to be careful, and the caution is advised in inducing decrease in blood pressure diastolic less than 60 millimeter mercury in patient with diabetes who is above the age of 60. And avoid to have a very wide pulse pressure. And the guidelines 2017, we have to differentiate between two kinds of elderly. The non-institutional patient who is 60 and above, but he is in good health, in whom the goal can be go to below 130/80. And in another patient who is old, but he has a lot of comorbidities. In this patient, we tend not to lower the blood pressure to below 130/80 and to watch the medicine we are using for the side effect. Now we go to what are the targets for blood pressure in coronary heart disease. It's up till 2015, it's less than 140/90 for patients for secondary prevention of cardiovascular event. But you can go to below 130/80 in individual with previous MI, stroke, or transient ischemic attack, or coronary heart disease risk equivalent. And when you have a stable angina with hypertension, the number one treatment is beta blockers, particularly in patients with previous MI. An ACE inhibitor can be added if you have prior myocardial infarction, left ventricular systolic dysfunction, diabetes. Thiazide can be added as well as number 3, and then you can have a combination if blood pressure does not. But if beta blocker is contraindicated and you think of non-dihydropyridine derivatives, you have to make sure that you don't use that in patients with left ventricular dysfunction. And if the patient has a high blood pressure, it's uncontrolled, you have to combine it with dihydropyridine derivatives. And stay away from beta blockers with non-dihydropyridine derivative, particularly in patient who has bradyarrhythmia. There is no special contraindication hypertensive patient with use of antiplatelets or anticoagulants. But blood pressure should be lowered without delay, because that's important concern, particularly when you use aspirin and platelets in a hypertensive patient. Lower the blood pressure, and you have to lower it without delay so that you will not have a risk of bleeding when you have an antiplatelet therapy. In 2017, it was clear there is two things. Blood pressure in patient with a stable heart disease should be below 130/80. Beta blocker should be used, but you should use the so-called GDMT, which is guideline-directed medical therapy, which are not all the beta blockers. It is atenolol, it is bisoprolol, carvedilol, and nebivolol. This kind of guideline-directed medical treatment is preferred in 2017 guidelines. The important thing is In adults with stable ischemic heart disease and angina and persistent uncontrolled hypertension, you can add dihydropyridine, and you have an MI, then you stay on beta blocker for 3 years, and that's 2A, or beyond 3 years in 2B if needs arise. So simply, in hypertension with stable ischemic heart disease, you reduce the blood pressure to below 130/80 and see if patient has angina. Then you have to add a dihydropyridine derivatives. And if he does not have an angina, you can choose whatever you want, a dihydropyridine or thiazide diuretics. Now we're coming to hypertension with acute coronary syndrome. The same thing, you have to start with beta blockers to make the diastole, to prolong the diastole so you improve the diastolic filling. And if the patient has ongoing ischemia, it's justifiable to use esmolol IV, but it is important in patients with acute coronary syndrome not to give him a beta blocker while he is congested. You have to give him diuretics, you have to stabilize before giving a beta blocker. Nitrates is important, lower the blood pressure, particularly in the IV, but it should be avoided if patient has right ventricular infarction or having a hemodynamic instability of hypotension. Non-dihydropyridine derivatives can be going, but you have to look carefully at the left ventricular dysfunction. And you can add dihydropyridine derivatives to the patients with beta blockers in order to relieve the anginal pain. ACE inhibitors or ARBs, these used in patients with anterior MI, hypertension persists, you can add them. So in the management of acute coronary syndrome, the target should be less than 140/80. In patients with acute coronary syndrome who are hemodynamically stable, and at the time of discharge, they should be less than 130/80. Blood pressure should be lowered slowly, and the caution is advised to avoid decrease in diastolic below 60 millimeter mercury because this reduces coronary perfusion and worsens ischemia. 2017, there was no mention on management of hypertension in acute coronary syndrome. So moving to heart failure of ischemic origin, what's your choice? The treatment of hypertension in patients with heart failure should include management of risk factors. That's essential. Drug has been shown to improve outcome in patients with heart failure with reduced ejection fraction, generally also lower blood pressure. Patients should be treated with ACE inhibitor, a beta blocker, also the GDMT, the carvedilol, metoprolol, bisoprolol, and nebivolol, and the aldosterone receptor antagonist. Thiazide diuretics. And in patients with severe heart failure and those with severe renal impairment, loop diuretics should be used for volume control, but they are less effective than thiazide in lowering blood pressure. And diuretics should be used together with ACE inhibitor ARBs in heart failure. Studies have shown equivalence of benefit of ACE and ARBs, and that's important. In heart failure, ACE and ARBs, they are equivalent in the patient, and you can see that in the candesartans and valsartan in heart failure with reduced ejection fraction. Either class of agent is effective in lowering blood pressure, and that's class 1 level of evidence A. You choose any of them. Coming 2017 in heart failure, in adults with increased risk of heart failure, the optimal blood pressure on hypertension should be less than 130/80. And in HFrEF, adults with HFrEF, reduced ejection fraction and hypertension should be prescribed GDMT again, titrated to attain blood pressure less than 130/80. Non-hydropyridine CCB are not recommended in the treatment of hypertension. In this kind of patient with hypertension and reduced ejection fraction, never to use non-hydropyridine derivatives, and it is harmful. In HFpEF, you use the diuretics and the volume overload, and then you can use ACE or ARBs. Beyond the pharmacology, you have to look for exercise training, sodium restriction, smoking cessation, reduction of risk factors like dyslipidemia, diabetes mellitus, and obesity. Now we come to other comorbidities in a few minutes. Cardiovascular comorbidities. Atrial fibrillation. The recommendation for atrial fibrillation is to use ARBs. Most of the data from the life study and ongoing one that the ARBs are beneficial in patients with hypertension and atrial fibrillation because of the afterload, they unload the ventricle and they prevent the stretch of the left atrium. Second thing, valvular heart disease. You have to start at gradually titrating upward low dose. And in patients with aortic regurg, avoid beta blockers. Why you avoid beta blockers in aortic regurg? Because you are increasing the diastole and you are increasing the regurgitation. In aortic disease, beta blockers are important. And they are the best treatment that preferred antihypertensive patient with hypertension and thoracic aortic disease. When you talk about some difficulty. Peripheral arterial disease, there is no preference. You can use any medicine in peripheral arterial disease, but stay away from those who are causing peripheral vasoconstriction. Now the final two slides. Actually, one of them in hypertension in patients with acute intracranial hemorrhage with hypertension. And it is very important not to tend to lower the blood pressure unless the systolic is above 220. Because when you above 220, systolic blood pressure lowering should be used, and it should be with IV infusion so that you can easily monitor the blood pressure. And the lowering of the blood pressure should not exceed 10 to 15% of the mean pressure. No attempt should be made to lower the blood pressure in a patient who are below 220, because bringing it to less than 140 at the time of the acute intracerebral hemorrhage, it causes harm more than benefit. And when you talk about ischemic stroke, it is very important to do one important thing, to see if the patient is eligible for IV thrombolysis or not. If the patient came for the first 3 hours and you will give him an IV thrombolysis, you have to make sure of several things. Number one, the systolic blood pressure should be lowered to 185 and below before you start. Number two, that the patient is not on any oral anticoagulant. And number three, that he is coming during the time, the 3 hours that you can interfere. And when you start with the 10% of the dose over the first minute, and the rest will be given over 1 hour. Other than this, don't lower the blood pressure except if it's above 220, because if you lower it further, you are going to increase the vasogenic edema and you are going to reduce the flow. I believe that this is my last slide, and I believe that in briefing we'll be able to give you some guidelines on the management of hypertension in various forms of cardiovascular disease. Thank you very much.
Okay, we are coming to the last of the talk of this section, and it is my pleasure to present to you Dr. Olivier Grison. Dr. Olivier is changing a little bit the subject. He's not talking about hypertension, and probably he cannot talk about hypertension because he's an expert in digital issues, and he will try to entertain us on the digital insight to better treat the patients. And this, I think, is a very important talk, because We know how to treat hypertension. We can discuss which is the best methodology and so on. But the medical community needs to be also instructed on all the modern possibility that we have to treat our patients. And that is exactly what Dr. Olivier Grison will do for us.
Thank you very much, Professor Ferrari. Salam alaikum. The pharmaceutical industry has got two main challenges. The first one is about finding new drugs to treat disease we can't treat. I'm thinking about some cancers, multiple sclerosis, Alzheimer. The second challenge is about dealing with some disease, such as hypertension or type 2 diabetes, for which we've got a lot of treatments, and for which a big issue might be the optimization of the management of the patient. Good afternoon, ladies and gentlemen. I'm a pharmacist and also specialist in digital technologies and working at Servier as head of digital marketing. And I would like to share with you some insights, 4 main axes in which we could better treat patients using technology. I'm not here to show you some kind of science fiction devices, high-tech things, but basic stuff, basic technologies that have demonstrated to be efficient. The first one, yes, it works, is about transforming the relationship between the patient and his treatment. Whatever the chronic disease, half of patients don't take their treatment correctly. Half of the patients. It's quite obvious when we talk about silent killers such as hypertension or type 2 diabetes. But research shows that even after a myocardial infarction, 1 week after discharge, we've lost 24% of patients, and a year after, 50% of patients. In terms of consequences, it leads to a dramatic increase of mortality of plus 12 to 25%, according to the sources, of mortality in case of MI, and plus 50 to 85% in case of coronary artery disease. And a recent paper in Diabetes Care demonstrates that patients who are observant, adherent to their treatment, manage to decrease their mortality in type 2 diabetes by minus 26%. This is a major issue. When you read this document, the recent guidelines on the management of hypertension, it states, you find again this figure that after 6 months, you've lost a third of your patient. After a year, you've lost half of your patients. Is it a problem we have just in Europe? For sure not. If we have a look at the American guidelines, this is a big book. You are the experts, I'm not. It's a big book of 500 pages. And when you look for information about medication adherence, there's not so much information. But there are 3 very interesting figures. The first one, 25% of patients would not take the first tablet. Wow. Second one, after a year, we've lost half of your patient in terms of medication adherence. And the last figure, maybe the most impressive one, only 1 patient out of 5 has a sufficient good adherence to achieve what is observed in clinical trials. Which means that in real life, all our world, which is made of clinical trials, only applies on 20% of patients. There's a problem here. When I downloaded this document, on the website of the American Heart Association, you can download a PowerPoint presentation. How do you manage hypertension? In fact, it's a big slide set made of 98 slides, so almost 100 slides. When you look for medication adherence inside, you get 2 slides. 2 slides for the other half of patients. The first one is this one. It states that to improve medication adherence, we need to put the maximum number of molecules in the same compound, in the same tablet, and we need to reduce the number of intakes. I'm working in the pharma industry, so we are very happy with this. We have made some combo drugs. Is it the magic bullet to kill medication non-adherence? For sure not. Well, I think we've got some echo. It helps, but it's not the magic bullet. The second slide set is this one. How do you manage hypertension? This is a table made of 16 lines. You can read Bijou office BP accurately, detect white coat hypertension, etc., etc. And you need to wait until line 14. Detect and reverse non-adherence. This is on this line that we are missing half of the patients. Wow. At Servier, we invited Professor John Weinman, who is a worldwide expert in medical psychology. And he gave some fantastic talks about the drivers of medication non-adherence. Among the most important drivers, you've got the cost or the side effects of therapies, for sure. But one of the most important drivers are the beliefs of the patient. If the patient thinks that his disease is not serious, he won't take his treatment. If he thinks that the treatment is not efficient, he won't take his treatment. And sometimes it's other types of beliefs. For instance, he said, take a patient who got a myocardial infarction. If you ask this guy, why did you get this MI? He would say, because I'm stressed. I'm stressed. And you know what? When I smoke a good cigarette, it helps me to get distressed. If the doctor says you need to stop smoking, who's this guy? He doesn't know my body as much as I know my own one body. I know deep in my heart that this cigarette is good for me. The patient is logical. He's wrong, but logical. How do you break such belief? First, by listening to the patient, and then with cognitive behavioral therapy, psychotherapy. That type of expertise can be used in some digital approaches. I will show you some examples. I think that one of the next ways to dramatically change the management of disease, here we've got the example of arterial hypertension, is to stop treating them, to stop treating arterial hypertension, and to start treating the hypertensive patient, which means taking into account his irrationality, his emotions. Each time I go to a medical congress, I'm often disappointed about the number of sessions involving psychologists. Generally, we've got cardiologists or experts or diabetologists, but psychology, I'm a pharmacist. During my pharmaceutical studies 20 years ago, I learned nice science, mathematics, physics, chemistry. And for the ones who failed their studies, they finished by learning psychology. And in fact, we never taught psychology at the university. I had 0 hours of psychology. And today, half of patients don't take their treatment. There's something wrong here. What about the pharma? Do we do better? I'm afraid not so much. We will spend between $1 to $5 billion to create a new drug. And to be honest with you, we can say that many of those new drugs might not bring so much innovation to patients. You have a lot of me-too drugs, for instance. In parallel, we make apps. We make a lot of apps. An app of this kind costs around 50,000 euros. It has never been tested on any patient. So let's summarize. $2.5 billion or euro in average for a drug, which might not bring all the time some substantial improvement. 50,000 euros for the other half of the 1.2 billion hypertensives in the world, or the other half of the 400 million diabetics in the world. There's something wrong again. Wow. Fortunately, the picture is not so dark. Let's take some examples. Sanofi. Sanofi has worked for many years, something like 15 years, about a fantastic product called Diabeo. Diabeo is an insulin dosage calculator. And they published the results of their study. It's a study for type 1 diabetics. The study is made of 3 arms. Control group, so just insulin. Insulin plus the calculator. Insulin plus the calculator plus the call center. After 6 months, here is what they get. Voilà. We're going back. Voilà. No. Yeah, superb. After 6 months, you've got on the left the control group, in the middle is the app, and app plus call center. The difference, you've got roughly 1 point of HbA1c. I'm talking about patients who take their treatment seriously, type 1 diabetic patients. In type 2, you get a delta of 0.6 point of HbA1c, which is roughly what you get with the DPP-4. Simply because you are present with the patient and you help him to calculate better his dosage. In South Africa, Servier worked with Health Window. In fact, it's a company that works with many pharma companies. Health Window is connected onto the IT system of pharmacies. It's up to the pharmacist to enroll the patient. If the patient doesn't come back for his refill, the Health Window will call the patient. Okay, I'm glad to tell you that your drugs are waiting for you at the pharmacy. So they call the patient on behalf of the pharmacy. And of course, the pharma companies, we don't have access to patient data. If the patient says, yes, but I still have some at home, the guy says, why? You know, you need to take your tablets. It's very important. What are the results? I'm not allowed to present the results on a slide, but I can present them orally. We assessed it with our sales system. It can be a good way to assess medication adherence also. Each time a doctor prescribes 12 months of treatment, the patient takes 5.5 months of treatment. With this system, it increases to 8 months. You get plus 50% of medication adherence with just a phone call. Can you imagine the impact in terms of mortality of this simple phone call? Other examples. We are working with Atlantis Healthcare. This is a company that makes some patient support programs. And they have an interesting example in asthma, in which the problem of adherence is very serious also. What is interesting here is that those guys are working with Professor John Weinman, so they have a psychology-based approach. When the patient connects on the platform, we ask him, okay, could you rate the seriousness of your disease? Could you rate the efficacy of your treatment? And based on the patient's response, then you will have a tailor-made approach based on his beliefs. What is the impact? Yes? No? Up. No? Yes. The impact is in orange. You see that you have a dramatic improvement of medication adherence, but more interestingly, when the intervention stops, 6 months or 9 months later, you still have the effect. It works. Interesting. Another paper, I won't detail all of them for sure. This one comes from Medicare in the United States, 100,000 patients. In the active group, you had 12,000 patients, diabetic patients. You just send them some SMS to remind them to take their tablets. And you get 14% of medication adherence with just basic SMS. More recently, the FDA has approved a connected version of Abilify from Otsuka Pharmaceuticals. This drug is used for bipolar and schizophrenic patients. And in fact, in each compound, each tablet, you've got a chipset that the patient will swallow. When he swallows the drug, there is a signal which is emitted to the smartphone, and you can monitor it and do something. Personally, I don't know what they did with it. Is it just a pill reminder, or do they build something more sophisticated? But for sure, it can be interesting. Okay. I got it. The second axis is, could technology help to influence lifestyle? We know that we need to eat less, to smoke less, to move more, to drink less for people from France, and we don't do it. We don't do it because our brain is not wired to make a daily sacrifice to avoid a problem in 20 years. I'm always surprised when I read in the guidelines of the management of type 2 diabetes that one of the first measures we ask patients is to lose weight. Honestly, do you know anyone among your friends or family who has ever managed to lose weight? Someone who has ever managed to lose 5 kilograms but maintained over 5 years or 10 years? It's almost impossible. It's very difficult. Could technology help to empower the patient? A few years ago, 3 years ago, the American Heart Association published a review of the literature about the impact of mobile health on cardiovascular risk factors. Risk factors, you had smoking, diet, exercise, cholesterol, hypertension, and diabetes. The conclusion was that we've got a signal of efficacy. There's something, but the evidence is weak. We are talking about very small studies made of 30 patients, 40 patients on 3 weeks, 4 weeks. We are lacking of evidence. But the conclusion is the absence of evidence is not an evidence of absence of effectiveness. We just need trials. And here came my friend Pikachu. Pokemon Go. Pokemon Go is a video game that made the world crazy a few years ago. How does it work? On your smartphone, you've got the equivalent of a Google map, and you need to catch some Pokemons. And the system would tell you there is a rare Pokemon just 2 buildings ahead. Come on, get it. So you need to get it. But if you drive to get it, it doesn't work. Then you need to walk. It would be too easy. If you want to open a Pokemon egg, you need to walk 5 kilometers. Wow. What happened? Researchers of Microsoft and Stanford published a paper that demonstrated an increase of body activity of plus 26% on the players. I'm talking about teenagers who would prefer to play on their PlayStation. Now they walk. Could this science be used to empower patients? I'm not telling you to prescribe Pokemon to elderly patients, for sure not. But there's something behind to explore. Again, some of you might know this video game called Candy Crush. I am a gamer. I've got my PlayStation, and when I play with a video game, I pay, let's say, 50 euros to get it, and I will play for 1 or 2 months. What happened with this game? They decided to target a new part of the population, mainly women and elderly people who are not part of the classic target of the video game industry. And what happened? So the new players have played every day for a few minutes, sometimes more, and they were engaged not for 1 or 2 months, but for years. Isn't it what we want for patients? To do something every day for years? This company was purchased by Activision, which is a big player in the video game industry, for $6 billion. What did they purchase? They purchased this. The science which is in this book is called Hooked, How to Create Habit-Forming Products. How do you manage to create new habits on patients? This is the bridge I want to make. And in fact, they explain through cognitive science all the mechanisms of addiction to technology. I won't detail them here. If you want, I have some more time after the conference. Couldn't we use this to better empower patients? One of the key messages of this talk is to say that to better treat patients, if I can have my slides, good, we need to use more cognitive science, and for sure the digital industry can help in this direction. This digital industry was born just 10 years ago with the iPhone. and see how much we are all addicted to technology. We've got some key learnings from this. Other question, could we follow patients now with technology? I know that in the field of cardiology, there were many things about the follow-up of heart failure patients, for instance. But I will give you another example, more impressive. In the field of oncology, I met Professor Fabrice Denis, who is an oncologist in France, and he decided to launch a very interesting clinical trial. I won't go into detail on the reasons of this clinical trial, but 120 patients suffering from advanced lung cancer, grade 3 and 4, with a median survival of 12 months. The first half is followed by classic imagery, one scanner every 3 months. The other half is followed without, but just a web formulary, a web page. Every week, the patient types some symptoms. You have an algorithm behind, and it's just a symptom-based approach for the management of lung cancer. The results were presented at the ASCO Congress in Hotline with a huge improvement of survival of plus 7 months, just because you follow the patients differently, in a closer way, thanks to just a symptom-based approach via a web form. The results, I should do it without slides. The results were published in GNCI, a famous journal, and were confirmed a year later by an American team on 800 patients suffering from metastatic cancer, and they managed to demonstrate an improvement of 5 months of survival. It's huge in the field of oncology. In the pharma industry, we need to demonstrate 2 months to get a marketing authorization for a new anti-cancer drug. Could we now treat, excuse me, but okay, patients with digital technology, just software? This is something that we did at Servier in the field of psychiatry. And we launched Deprexis. Deprexis is an online psychotherapy. What is interesting? It's a medical device. The efficacy of the system is supported by clinical trials. It's not 12, but 13 clinical trials. And it's reimbursed. I mean, the payers in Germany recognize the efficacy of this program. The challenges for us is acceptance by healthcare professionals. Some doctors told us, "You're nice guys, but you are stealing my job," which is quite new for us as a pharma company. We're not used to that type of objection. The second challenge is about market access. Health authorities don't feel comfortable in assessing that type of device or drug. This could be used, not in the field of depression, but these methods could be used, for instance, for patient empowerment in cardiology, if you want to convince a patient to stop smoking or start losing weight. What are the next challenges? The next challenge, in fact, why do you prescribe drugs? What's behind a drug? Behind a drug, you get this. Clinical trials, publications, presentation in congresses, pharmacovigilance, etc. It's a big machine. Why do doctors prescribe apps? Because it's cool, high-tech, and the rep was very nice. And while some consultancy firms say that the patient is a new customer, personally I think that no, the patient is a patient. He's someone who is frail and for which we don't want to play. We need to treat him. And therefore, research shows that many doctors, most doctors, don't prescribe apps. In fact, for many years, we were wrong. In the digital industry, we tried to convince you to speak the language of digital. But medicine is conservative, and it has to be. So in fact, we have to do the contrary. It's up to the digital industry to speak the medical language, which means medical publications, studies, congresses, and so on. Otherwise, it won't be adopted. So the next step in this domain will be to provide medical evidence regulatory guidances, but health authorities are already working on them. And the main challenge is the integration into the healthcare system. If I have a pilot that demonstrates some efficacy in 2 or 3 hospitals, how do I upscale it to 500 hospitals? How do I cover a country or a continent? Today, no one managed really to do it. It's very, very difficult. If I go back to chronic disease, in the pharma, when we launch a drug, we get a new price for this new drug, and then the price decreases, and here comes the first generics, and we get something of this kind. And at the end, we don't make a lot of money on this drug, so we make another drug. But if we go back to hypertension, shall we work to treat even better the ones who are already well treated, or shouldn't we also focus on, in gray, the ones who don't take their treatment? The medical need is also here on those patients that we don't find very often in medical congresses. So the future of the pharma, is it to recreate another antihypertensive drug? Difficult. There are so many on the market. I think the future of pharma will be to switch from drug providers to medical service providers, to work with different stakeholders to create those beyond-the-pill solutions. But it's difficult. It's difficult because if we want to do something that works, we need to work with all those guys. Doctors, nurses, pharmacists, competitors, health authorities, university, etc. Each time we try to work with one of those boxes, it's very difficult for us. So imagine working with all of them at the same time. So what shall we do? We give up? Have you heard about those guys? Uber, Netflix, Airbnb. Those big players from the Silicon Valley. They have disrupted all the economic sectors worldwide, except health, for the moment. They have two things in common. They focus mainly on the real need of the final customer, or in our domain, the patient. It could be the patient. And the second point is that they don't care about the existing structures, the existing silos. They recreate things from scratch. And if people say, yes, Olivier, you're nice, but health is different. We are in a regulated environment. Yes, it's right. But I'm French. And I've seen those guys from Uber disrupting the taxis in Paris. Believe me, if they could disrupt French taxis, they can disrupt anything. Before finishing this talk, I know that many of you, most of you, were involved in this program, because I say so, which was a big detection program in hypertension. And I will profit to be here with you to thank you. To thank you because Saudi Arabia was one of the best players in this huge worldwide detection program, which managed to reach 15 million of persons worldwide. So on behalf of the staff at Servier at the head office, but also all subsidiaries, I finish my presentation by thanking you. Thanks very much for your attention.
Thank you very much for all the speakers. We'll call the speakers for the discussion, please. Dr. Tawfiq Bassam, Professor Mustafa Kemal Erol, Dr. Tahir Hassan, and Dr. Olivier. Can we have the microphone here working? It's not working. No, okay. So if anybody has any question, we will start. Professor Roberto Ferrari, he's the co-chairman of the session, and he can start the discussion and questions. He's our privileged, distinguished speaker, invited speaker to our meeting.
If I have to ask a question, I would like to start with the last talk And I fully agree that particularly, hear me? I fully agree that particularly in hypertension we are not successful in convincing our patients to take the drugs, which are available, effective and cheap. So it's not a question of money. In many countries where I'm working, for instance, drugs are completely free, so it's not a question of cost. It's just a question of conviction. You mentioned that digital can help, but you didn't exactly told me how can help. For instance, I myself, that I am a computer virgin, I made an application with the Faculty of Mathematics, not for hypertension, but for self-calculating the risk chart for cardiovascular disease. This was an application provided to the population of the city where I'm working and living, the city of Ferrara. And once that we had this application, which by the way you can go and look at it, and we tried to make it as attractive as possible using designers and so on, then we started to do some publicity through newspaper, through the football team. You know, every football match there was a big screen saying, please go and do your self-assessment for cardiovascular disease from the University of Ferrara and so on. A lot of enthusiasm for the first 2 or 3 months. Now, every time that the football team, which is in the superior, in the highest level, is playing, still there is all of this. Still, we are going to newspapers, schools, and so on. But it seems to me that the interest for the digital stuff, like all these watches for running and so on, does not last very long. And we are dealing with chronic disease, which could be a solution.
This is a very tricky question.
We need a short answer.
And this will be a short answer, yes. First of all, we are all different. If I had to convince each of you to stop smoking, for instance, I would use for each of you different arguments. And I will use my second job, which is about digital marketing. And for this, we have what we call multi-channel marketing. The fact that today in your digital life, you are surrounded by ads, and some channels are more efficient for you or for another one. So, first of all, to reach the first time the persons, yes, we have some tools. The second one, about long-term engagement, for sure those solutions might not last for 30 years like for drugs. So we need to renew the concept. The Fitbit and all the activity trackers, we all know those wristbands. We use them for 2 weeks, and then now I know that I'm walking 9,000 steps a day. I don't care about it anymore. Why? Because this device gives me figures, meaningless figures. If I have an app that gives me my blood pressure, it doesn't make any sense to me. If I convert those complex figures, systolic, I don't even know how to spell it for the patient. If we convert it into something gamified, and we use those techniques used by the video game industry, those guys managed to hook people for years. We just need to have new stakeholders in the world of medicine to learn from them, I think.
Thank you very much indeed. Do we have any question from the audience or comment? Yes.
My question on the renal denervation. And simplicity, the sham worked very well, and there is like very good reduction in blood pressure. And the recent Lancet trial, the sham did not work at all. So what is your comment on this?
Prof. Mustafa.
In previous studies, simplicity H10-3, there was no. I couldn't understand. You asking this sham procedure didn't work in between studies?
Bring it closer, closer. Closer.
Yes. Yes. In simplicity 3, in sham control study, sham control groups, blood pressure decreases significantly, but in last studies not. You asked to say, I understand. In simplicity 3, maybe the drug adherence not check. Drug adherence may be a factor for this because the last studies drug adherence was detected by urine or blood test, but before the first studies, not drug adherence assessed. Maybe a factor, but fully I don't know.
Yeah, it's very good that in the new European Society of Hypertension, European Society of Cardiology guidelines, they have mentioned very clearly that recommendation is 3 for any interventional management for patients with hypertension, unless it is really going for trials. Randomized, controlled trials. So until now, I mean, not everybody is in favor of having any interventional management for the patients with the resistant hypertension. Do you agree with that?
Now, at the moment, I agree. But last second generation studies injected a new optimism. And it's very early to say recommend routine use the renal denervation. But after the long-term follow-up, if this decrease persisted the 2 or 3 years, I think new guidelines will change the recommendation again.
Dr. Tawfiq?
Yes, may I have a comment, please?
Yes.
I think not only the European, even the American guidelines, even the Canadians, up to now, 2018, they do not recommend renal denervation to be used in resistant hypertension, only for research purposes.
Yes.
The reason behind that is because we had a problem before. Many patients were put for renal denervation, they didn't have resistant hypertension at all. Now we start to know, so we want to avoid repeating the mistake again.
Yeah, I agree with you, because now there is Michael Baum presentation with the study he did for renal denervation. It was done renal denervation for patients who does not have resistant hypertension, and they did not start on medication. They are off medication, naive for medication, mild to moderate hypertension, and he did renal denervation and he showed improvement. But this is continued to be randomized controlled trials more than for clinical practice. Professor Roberto?
Well, I would like to make a general comment, because renal denervation, ablation of atrial fibrillation, and so on, to me, a really bad example on how you should destroy a possible good idea. We learned from your presentation that some of these trials were not conducted well. We heard that some of the renal denervation were not done in the 4 areas as they should. And very often people, particularly when there is a device and so on, they are pushed to do, they like to do it, they like to come out of the cath lab and saying, I've made it, and they do it badly. And we construct clinical trial with, at the end, bad results simply because the procedure was not made perfectly well. And that will frozen the future research, because nowadays nobody is doing renal denervation because we are all convinced that it's not good enough to reduce the blood pressure in really resistant people. It's the same with atrial fibrillation, with ablation of atrial fibrillation. Do we have a sham-operated trial? No. And we just accept it. And we all know that 30 to 40% of the patients is coming back and so on. We all know that some of the ablation are not done properly, are not done with the right technology and so on. So my message is, if you participate in a trial, it's not just to participate. It's not just to get the money for participation to the trial. It's part of medicine. To participate in a trial is a duty that we do have as a doctor, but we have to do it properly. Because if we don't do it properly, we might, and it's the same that's happened with stem cells. Everybody injected stem cells without knowing what to do. The end results, we are not even considering anymore stem cells, because the study was not done properly. And in this respect, I have to say that the drug companies, probably because they have to fulfill several points in order to have their drugs approved, at least they are trying to do the best possible clinical trial, but not the device company. And that is a big problem.
Thank you. We have time for one question, if anybody has. I have one question to Dr. Tahir, really, and this is always in our clinical practice. Patients with hypertension and coronary artery disease. Most of the time, these patients, they are more of elderly. They are not very young. And in elderly patients, we have diastolic blood pressure slightly low, systolic slightly high. When you will use medication, it might decrease both. So what will be your advice, comment on that issue? Do you want to come here, Dr. Tahir? No? You can use this one if you want.
This is a good question. Actually, patients with coronary artery disease, they depend on their perfusion on the diastolic time. They perfuse in diastole. And it's important things not to lower it very aggressively, and at the same time don't make it short by using medication that accelerate the heart rate. And we will see that patients in whom you lower the blood pressure aggressively, or you give them medication that increase their heart rate, they might end up in extending their infarction, or if you take the beta blockers out suddenly. And they are different from those who are revascularized. Patients who are revascularized, they have a different response to that. So it is important, the first thing to do is to slow the heart rate, make the blood pressure recently decreased, and at the same time keep an eye on anything that can reduce perfusions. And by doing that, patients will get benefit. Thank you.
Thank you very much indeed. Before we'll end the session, we'd like to Professor Mustafa Kemal Erol, and we'll have photo together. Where is the photo man? Disappearing as usual.
Professor Takvim Al-Hassan.
Prof. Tahir Hassan. We have finished this session. We'll have break, 10 minutes, break and coffee break, and we'll be back to the fourth session of our meeting today. Please be on time. We will not call you because we will start on time after 10 minutes. Thank you.
Test.
Just housekeeping note, really, that we'll be having ceremony also, meeting together for the speakers and the moderators at 7 p.m. here. So we'd like to invite the speakers and moderators, and we'll have photo together at 7 p.m. Thank you.
1, 2, 3, 1, 2, 3. Test.
Good afternoon, my colleagues. It's time to start the new session. This session is Hypertension Management 2. We will co-chair in this session Mrs. Erman Ashkar.
Dr. Nawal Basri. Yes.
Yes. Please open. And
yes, and Dr. Nawal Basri.
Okay. And this session, first speaker, Dr. Sami Senjat. His topic is monogenic syndrome of salt-sensitive hypertension. Dr. Sami, please.
Good afternoon, and thank you all for staying this late. I know that, with time people get tired and start, wanting to take a nap. So that's fine with me. I think you're good quality, and that's what counts. I'd like to thank the organizing committee, and specifically Dr. Saleh Shurafa, for inviting me to this conference. Saleh has done an outstanding job in, getting all these fine people together, and I think I'll congratulate him for a very successful conference. My topic is about monogenic syndromes of salt-sensitive hypertension. It's well known that genetic factors contribute to about 40 to 50% of blood pressure variation. Yet, less than 3% of known genetic factors actually do exist that have been identified. In other words, we're still a long, long way to identifying all the genetic causes of hypertension. So there probably are more than just the single genes that we'll be talking about. We'll also probably have gene-gene interaction, epigenetic factors, etc. Okay, so it's working? Not working? Anyway, so this is the outline of my topic, of my presentation. We'll talk about when to suspect monogenic hypertension. In other words, when should you really think about it after ruling out secondary hypertension? We'll talk about some of the recently and not so recently described syndromes of salt sensitivity. We'll talk about the genetics and pathophysiology of these hereditary syndromes, which are very, very interesting, and we have learned a lot from them. And finally, we'll talk about the implications of salt sensitivity in the etiology and treatment of essential hypertension. So when do we suspect monogenic hypertension? After ruling out secondary causes of hypertension, which in children are usually due to renal parenchymal disease or renovascular disease, then we should strongly consider monogenic hypertension if it's an early onset, early life hypertension. You should keep that in mind. You should also consider the severity of hypertension. In other words, if the hypertension is very severe in a young child and refractory to treatment, then again, this should be an indication that you might be dealing with the monogenic Mendelian type of salt-sensitive hypertension. Family history is very important. If you have consanguineous parents, if there is a family history in one of the parents, particularly starting at an early age, this again should alert you to the possibility that you're dealing with a single gene related to hypertension. And sometimes suggestive findings from the physical exam, for instance, a child who is failing to thrive, ambiguous genitalia and so on, this might be again indications that you might be dealing with monogenic hypertension. And lastly, the biochemical abnormality, the laboratory findings can be very, very suggestive, particularly if you find hypertension with hypokalemia and alkalosis, and rarely with acidosis and hyperkalemia. This is a strong suggestion that you might be dealing with one of those syndromes I'll be talking about. Now, all these syndromes share one thing in common, in that they are all salt sensitive. In other words, they have a propensity to retain salt and do not excrete it appropriately. The salt retention takes place at 3 different levels. We'll be talking about this. In fact, I'll be repeating it throughout this talk. You might get bored because it's important to repeat what happens. So, first of all, there is impaired renal excretion that leads to sodium retention, increased extracellular fluid volume with the expansion of ECV. This stimulates brain endogenous wabain, and wabain finally, together with the stimulation of the adrenal cortex, generate a very interesting, let me get my pointer. No. Anyway, there is a new, not new, but an identified substance known as adrenocortical MBG, marinobufagenin, and this is a very potent vasoconstrictor. It acts actually on the sodium-potassium ATPase pump and leads to increased cell sodium, increased cell calcium, severe vasoconstriction, and hypertension. This substance is also known to promote diuresis, but when it's found in excess amounts, it doesn't. They don't work. See. No. Anyway, so this is the basic mechanism that underlies all the syndromes I'm talking about: salt retention, expansion of extracellular fluid volume, wabain secretion, marinobufagenin, which is a very potent vasoconstrictor, and this is how they develop hypertension. Now, having said that, there are 2 basic mechanisms for inheriting these syndromes. Most of them are autosomal dominant. In other words, usually one of the parents or grandparents has the disease, and only 2 of these are recessive genes. The dominants are listed here: Liddle syndrome, familial hyperaldosteronism, known as GRA, and there is 4 of them, and the Gordon syndrome and Geller syndrome. The recessive syndromes are the apparent mineralocorticoid excess, or AME, and the congenital adrenal hyperplasia. I will not be talking much about this. I think Dr. Al-Beiruti will be talking about endocrine hypertension tomorrow, so she will probably cover those in more detail. Now, again, as I stated at the offset, that these are all syndromes of extreme salt retention. And they all are related to excessive sodium transport across the renal tubules. This happens primarily at the level of the distal collecting tubules and the cortical collecting ducts. Okay, distal convoluted tubules, and there are 2 mechanisms by which this takes place, either due to increased sodium transport by a mineralocorticoid effect, or increased sodium transport independent of mineralocorticoid effect. In other words, in these 3 syndromes here, Gordon's, Liddle's, and Geller syndrome, there is a constitutive thing that helps the kidney absorb regardless of a stimulus to reabsorption. In other words, it's a genetic mutation within the transporter, within the channel, within the receptor that enhances further absorption. While in the other 3, syndrome of AME, apparent mineralocorticoid excess, glucocorticoid, remediable aldosteronism, and congenital adrenal hyperplasia, there is a circulating or a local mineralocorticoid that is actually leading the effect for salt retention. Again, I'm repeating myself, but this is just to show you the site where this actually takes place. Okay, this is, if you remember your anatomy, histology, physiology, you have a glomerulus that is not showing on this pointer, doesn't reflect. Anyway, the glomerulus, and then you have the area known as the NCT. NCT is a sodium chloride co-transporter that is a thiazide-sensitive transporter that enhances sodium reabsorption in the distal convoluted tubule. So these are very specialized transporters that are present in everybody. We all have those transporters. And they're very tightly regulated by the amount of sodium we eat. If you eat too much sodium, they don't reabsorb excessively. But in patients who have diseases that we're talking about, they may have mutations in this thiazide-sensitive or in the sodium epithelial channel further downstream in the collecting tubule. Okay, so these are the two types, or three types of cells actually, the thiazide-sensitive distal convoluted tubule, the principal cell of the collecting duct, which has the sodium channels, and the mineralocorticoid receptor that is the one that mediates all this absorption. So we'll start with the first disease known as GRA, or glucocorticoid remediable aldosteronism, dexamethasone suppressible aldosteronism, or familial hyperaldosteronism type 1. This was originally described by Sutherland and then by Brahim Salti, who was a friend of mine, in the late 60s. And it presents with hypertension, a young child or a young adult, and it can be fairly severe and associated with the CNS complications, including strokes due to ruptured cerebral aneurysms. Hypokalemia is found in about 50%, and obviously hyperaldosteronism and with low renin. So all these syndromes have low renin activity, they're low circulating plasma renin. They all have extracellular fluid volume expansion and suppressed renin. This is probably one of the easiest diseases to treat because they respond to glucocorticoids. You need to suppress the ACTH, and they respond very well to that. Or you can also resort to to spironolactones or mineralocorticoid antagonists. Now, the genotype was discovered more than 30 years later, and it turns out it's an autosomal dominant mode of inheritance, and it's actually due to an asymmetric fusion of two genes, the aldosterone synthase gene and the 11-beta hydroxylase gene. Now, this results in a hybrid gene that brings aldosterone under ACTH rather than angiotensin II. So the aldosterone will be secreted from the zona reticularis rather than the zona glomerulosa, and these patients develop sustained severe elevation of blood pressure. Typically, they have elevated 11 carbon oxidation products in the urine. Now, this is to show you what happens, and I'll not elaborate. These are the two genes, the aldosterone synthase gene and 11-hydroxylase gene in the upper part of the slide. They fuse, but during meiosis, they don't fuse properly. And this leads to the fact that ACTH, instead of, this is what's normal on the left side, ACTH aldosterone is usually stimulated by angiotensin II, whereas in these patients it's due to, it's stimulated by ACTH and the zona reticularis. So this is a continuing elevation of the plasma aldosterone level. So the other syndrome is Gordon's. Gordon's syndrome is known as pseudo-hypoaldosteronism type 2, and this is the only syndrome that I'm talking about that is associated with hyperkalemia. All others have hypokalemic alkalosis. These patients have hyperkalemic acidosis. We studied a couple of these patients, and all these are rare diseases incidentally, but they have really taught us a lot in the etiology and pathophysiology of hypertension. So needless to say, this is all salt sensitive. Again, diagnosed at a young age, hyperkalemia with a normal GFR, metabolic acidosis, which can be very, very tricky to diagnose, really. It's a hyperchloremic acidosis, a type 4 RTA, if you remember it. Again, low renin, no aldosterone, and even prostaglandins are low. We originally thought this was the diametrically opposite syndrome of Bartter syndrome. It turns out it is just not the case. It's actually the opposite of Gittelman syndrome, if you remember those syndromes. And a nice thing that they respond to low-dose thiazide diuretics. And then I'll show you why. Again, the genotype was discovered, again, many, many years later, 30 years later. Again, mostly autosomal dominant. There is only one variant that is recessive, and these are the chromosomal locations. And then it turns out there are some threonine kinases, some protein transporters that have a gain or loss of function that somehow accentuate or potentiate this transporter. Okay? And these last two, KUL3 and KHL3, were discovered only 4 or 5 years ago. So this is what happens in Gordon syndrome. Remember, I was telling you about the sodium chloride co-transporter in the lumen and the distal connecting tubule. Now, these transporters for somehow undergo a gain of function mutation and activate this transporter. So there is constant stimulation of the transporter to keep on reabsorbing sodium chloride. So they, again, through the same mechanism of salt expansion, of volume expansion, stimulation of the factors I mentioned about with vasoconstriction and hypertension. So there is gain of function of this transporter known as the WINK1 or loss of function of WINK4 that lead to activation or constant stimulation of the sodium chloride co-transporter. Now the next syndrome is pseudo-hypoaldosteronism or Lidus syndrome. Pseudo-hyperaldosteronism, sorry. This was again described more than 50 years ago. The phenotype, again, with the hypokalemic alkalosis, low renin and so on. And until recently, we didn't know how to treat those patients. They were treated with conventional antihypertensives until we found out that they're actually, the disease is due to gain of function mutations in the sodium epithelial channel. The sodium epithelial channel is located, as I showed you earlier, in the principal cell of the collecting duct, and this is tightly regulated by these subunits. So the increase in the number of channels is what leads to this sustained absorption of sodium. So what happens is that the mutations in the ENaC, or the sodium epithelial channel, will lead to increased number of channels, decreased degradation of the channels, so they remain open for longer periods of time. There is enhanced sodium reabsorption, increased potassium secretion, and again, the same old story, expansion of extracellular fluid volume with hypertension. So this is what happens at the cellular level. This is the normal cell on the left side, the principal cell and the collecting duct on the left side. And this is one on the right side where the channels, the sodium channels, have increased in number, and the PO, or the potential for openness, remains higher, so they keep reabsorbing sodium relentlessly, regardless of the stimulus. So this is what so this disease actually responds to sodium channel blockers, namely amiloride or triamterene. This is how they treat these patients. You don't need aldactone, will not work. Antihypertensives, conventional, do not work. They just need amiloride, a sodium channel blocker. And then there's the syndrome of AME, or apparent mineralocorticoid excess, again described more than 40 years ago. Phenotypically, it's identical to Liddle syndrome, very difficult to differentiate. They all have early onset hypertension, hypokalemic alkalosis, low renin, low aldosterone. Here they respond to mineralocorticoid antagonists, spironolactone or eplerenone. The genotype, again, was discovered more than 20 years later. Again, against a recessive gene. This is the only recessive gene that, and congenital adrenal hyperplasia. And this is a very interesting disease because there is an acquired form of this disease. And if you ever been to Holland, where licorice is consumed in very, very large amounts, they develop a licorice-induced hypertension. Licorice causes exactly the same thing that these patients have as an inherited disease. So the disease is due to mutations, loss of function mutations in the 11-beta hydroxysteroid dehydrogenase type 2. So this is an enzyme I'll show in a minute. Again, as I said, it's inhibited by licorice and carbenoxolone. This is an enzyme that, interestingly, in the mineralocorticoid, in the principal cell of the collecting duct, it converts cortisol to cortisone. Okay, again, it's unfortunate we can't point, but as you can see on the right side, cortisol is converted to cortisone, and cortisol has a very potent mineralocorticoid effect. So it's probably as potent as aldosterone because it circulates in very, very high concentration. So were it not for this hormone, 11-beta hydroxysteroid dehydrogenase, it will remain very high. So this hormone converts it into cortisone, which has no effect on the mineralocorticoid receptor. So this is under normal situation. When this enzyme is missing, cortisol will circulate in high concentrations and will lead to hypertension, again stimulating the mineralocorticoid and affecting the sodium epithelial channel.
Prof, could you conclude in 2 minutes, please?
Okay, finally we have congenital adrenal I thought I had 30 minutes. Congenital adrenal hyperplasia, which is, again, there are two types, type 4 and type 5. One is 11-beta hydroxylase deficiency. The other is 17-hydroxylase deficiency. The phenotype is characteristic. They present with ambiguous genitalia in girls, and in boys, precocious puberty. Type 5, 17-hydroxylase deficiency is just the opposite, primary amenorrhea in girls and ambiguous genitalia in boys. They both respond to mineralocorticoid antagonists. The last syndrome is the Geller syndrome. This was recently described about 18 years ago. And again, it's a dominant trait. Again, early onset hypertension, exacerbated during pregnancy. This is a disease of pregnancy, really. And here there is a mutation, a point mutation in the mineralocorticoid receptor that changes serine to leucine, and it alters the receptor specificity to the extent that progesterone becomes an agonist instead of antagonist. Okay, so this is a summary of what happens to all these syndromes. Okay, you have the adrenal gland down here. You have syndromes of aldosterone excess. You have the AME, which is due to 11-beta hydroxysteroid dehydrogenase deficiency. This is not working. Okay. Then you have the congenital adrenal hyperplasia I just talked about. Not working. Anyway, so can you change the slides? Okay, so this is the summary of the treatment. All these diseases, as I said, share one thing in common. They all have extracellular fluid volume expansion. They all have low plasma renin circulation. They all have low aldosterone, except for the familial hyperaldosteronism, as it's implicit. And the treatment really consists primarily of mineralocorticoid antagonists in most of these cases, except, of course, in Gordon syndrome, where thiazide is the treatment, and in Liddle syndrome, where sodium channel blockers is used. And finally, to summarize what I've been saying for the last 25 minutes, mutations in these transporters and mineralocorticoid receptor can mimic a state of mineralocorticoid excess leading to hypertension. These are the diseases: Liddle's, Gordon's, and Geller's. Mutations in adrenal steroid enzymes lead to their deficiency, lead to buildup of precursors such as congenital adrenal hyperplasia and AME. And then mutations in the aldosterone pathway lead to excessive aldosynthesis. Hormonal studies coupled with genetic testing can help in diagnosing all these diseases and apply early treatment. Thank you.
Thank you. The next speaker, I'm going to invite Dr. Ashraf Amir. Dr. Ashraf Amir is a consultant family medicine at the International Medical Center. Please, Dr. Ashraf, he's going to talk to you about hypertension and smoking.
طيب الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Dear colleagues, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank you for attending my session, and I would like to thank the organizing committee for inviting me today in this very prestigious conference to talk about a very important topic that we all encounter in our daily practice. And let me start by a statement to say that all of us, we agree that most of the chronic disease that we have in our population in Saudi Arabia, like hypertension, diabetes, ischemic heart disease, cardiovascular disease, are always connected strongly to a modifiable risk factors like weight, obesity, improper diet, exercise, as well as smoking. And in fact, smoking is the most important modifiable risk factor for cardiovascular disease, and smoking is always associated with a high risk of cardiovascular mortality and morbidity. So within this coming 20 minutes, I will try to limit myself to the short time given, but I will try to bring the associations and to prove to you through certain evidence that there is an association between hypertension and smoking, cigarette smoking, or even tobacco smoking. So my objective in this presentation, just only two objectives. One is to walk you through certain evidence to make sure that there is a strong association between tobacco smoking and hypertension. And then the most important part of my presentation will be at the end, which will be highlighting and emphasizing our roles as physicians to tackle this kind of problem among our patients, regardless of our specialty. So we are going to talk a little bit today about tobacco smoking and hypertension. So you will see that I'm trying to separate hypertension alone and tobacco smoking alone to start with, and then I will combine them together. So as you know, according to the latest evidence about the prevalence of hypertension in our society, which has been published in the Saudi Hypertension Guidelines in 2018, of course, there is many trials, cross-sectional trials, but the one which is more appropriate is the Saudi Health Interview Survey, which was published in 2013, and it demonstrated that the prevalence of hypertension is 15.2. But the question here, are we doing good in managing our patients with hypertension? Definitely no. Why? Because we have only 5.4% of our hypertensive patients, they have been treated to the target. Again, we have almost done 78% of our patients who are hypertensive, yet not yet diagnosed. So there is a huge problem, and of course we have multiple factors contributing to this. One is patient factor, one is physician factors. We have a clinical inertia to manage this kind of cases, and then ultimately the last one is the healthcare system factors. So let's go through the prevalence of smoking in our society. According to the Tobacco Atlas, which was published a couple of months ago this year, they have distributed the demographic or the geographical distributions of the smoker across the globe. So what is the share of these populations of smokers in our region in the Middle East, particularly in Saudi Arabia? They're about 20 to 40%. But according to the statistics which has been highlighted, we have 20 to 30% of our Saudi populations, they are smokers. And unfortunately, we have a new population group has been added on top of what we have, those who are teenagers, ladies who are pregnant, and again, the healthcare providers. So unfortunately, there is about 40% and more in Turkey of the healthcare providers, they are smokers, and they are not presenting themselves very professionally when they are presenting themselves as a vehicle of healers to treat certain disease. So we have to maintain the role of model to ensure that we can deliver the message clearly and with a good acceptance from the other end, who is the patient. I thought just to highlight the important part about the component of the cigarettes. It's not all about nicotine, which causes the addictions. We have more than 4,000 different chemicals. We have more than 250 toxic substances and a lot of carcinogenics. And this promotes the smokers to have multiple comorbidities and mortalities because of these substances. But what the drugs, the tobacco industrious companies, what they have done in the previous years, in the past 1 or 2 decades, they have added certain substances to enhance the adherence of the smoker to the cigarette. So they have added bronchodilators in order to bronchodilate, the bronchus to inhale or to accommodate a larger capacity of the smoke. And then they have increased the nicotine to make the smoker more addicted. They have added certain substances like the menthol, which cause the soothing of the throat and make the smoker more pleasant and relieve the irritations. Many substances has been added, and the ultimate goal was to keep our patients and our people more addictive to cigarettes. So to know that there is no single organ, there is no single system in the human body is deprived from the bad effect of cigarettes. So there is a big list of chronic disease. The most important one is the cardiovascular disease and the COPD. We have a big list of cancers, just name it, from the lung to the stomach to the bladder and so forth. But if you want to summarize what is the bad effect of the smoking on the health of the individual, so it's a cardiovascular disease, which will be followed by the COPDs and certain cancer. And it is usually duration related. So those who smoke for a longer period of time, they have more complicated, and even the durations and the dose. The more they smoke, the duration more, definitely they will have more complications. So my question to you, how many current smokers will eventually be killed by their tobacco use? Is it 1 in 20, 1 in 10, 1 in 2? Anyone? Anyone? Thank you very much. So it is 1 in 2. So they said the only legal product available to the customer that caused the death of about 50% of its regular users is a cigarette smoking. So it kills 50%. 1 of each 2 are killed because of this. And this is one of the studies which has been highlighted, that there is a span of the survival of 10 years between the smoker and non-smoker in a survey which has been extended for many years. And there was no difference at the age of 40 between the 2 groups, but when they advance in age, at the age of 60 or 70, there was a span of 10 years survival in favor of non-smoker. So here the question and the main objective of my presentation: can tobacco smoke lead to hypertension? I will walk you through certain studies. So this is one of the studies to show the effect of smoking on the blood pressure in normotensive men. And this was conducted in Manipal University in Mangalore in India. It involved more than 2,000 workers in a factory in India. And after 6 months, the same subjects were examined, and the result was there was a rise in the blood pressure, systolic blood pressure in the smoker compared to non-smoker. Another study, which was a prospective study of cigarette smoking and the risk of incidence hypertension in women, and this was in Boston. So it's extended to almost 10 years with populations of women of more than 28,000. And they have no hypertension, no cardiovascular disease, and no cancer at all to start with. But what happens? And this is the baseline, in fact. You can see that among the population whom have been studied in this trial, 50% were non-smoker, 36% they were ex-smoker, and those who smoke less than 14 cigarettes per day, there were only 5, and those who smoke more than 15 cigarettes per day, there were 8%. So let's see what was the result after 8 years. So there were almost 30% of those patients or those people or women who were involved in this study, and they were not normotensive. They become, after 9 years, about 30% of them, they were hypertensive. And the conclusion was, in a large cohort of men, cigarette smoking was associated with an increased risk of developing hypertension, with an effect that was strongly among women who smokes more than 15 cigarettes per day. So the durations and even the dose was contributing to the high prevalence of hypertension. Of course, the cardiovascular mortality for the current smoker usually rises between 1.5 to 3-folds. And we can see here in this slide, the death from all vascular disease is about 3-folds. Death from ischemic heart disease was almost 3.5-folds, and death from stroke was about 3.2-folds, and death from other vascular disease was in male more than 3-folds. So the conclusion was smoking increased the individual risk of death for all vascular disease by about 1.5 to 3-folds. So if we just identify smoking, hypertension, and hyperlipidemia as a different entity, but they are having a contribution to the cardiovascular risk and cardiovascular mortality and morbidity. So as we know, the smoking will increase the risk for cardiovascular disease by 1.5, hypertension by 3-folds, hyperlipidemia by 4. But if you just combine smoking and hypertension, so the folds will be up to 4.5 risk of cardiovascular disease. And if you combine smoking with dyslipidemia, the risk will be as high as 6. But if you just combine it all together, and many of our patients, they have this kind of combinations, so definitely the risk will be very devastating that the patient will be a victim of cardiovascular mortality and morbidity. So let's go through the mechanism and understand a little bit about the pathophysiology of this tobacco smoking and how it affects the cardiovascular functions. So the two important elements that we would like to focus is the nicotine and the carbon monoxide. So here, if you just can have a look on this, so the smoking, if we just take the nicotine out of the smoking, so there will be a vascular dysfunction. So it increases it's not clear. I will have a look at it here. Okay. Right. Anyhow, so it causes a vascular dysfunctions, and it affects the lipid metabolism, and it develops atherosclerosis, and it causes a lot of and it increases the sympathetic activities and ultimately increase the blood pressure. And all these factors, when they are contributed together, they affect they cause the dysfunctions of the cardiovascular system because of the endothelial dysfunction, and ultimately they result in myocardial ischemia and all the complications of the cardiovascular functions. So to conclude, because the slide wasn't very clear, I apologize for this, but to conclude, what is the effect which is mediated by the nicotine on the cardiovascular system? So definitely there will be a sympathetic nervous system stimulations, and this will result in hypertension, increase in the catecholamines release, and this ultimately causes the hypertension, and increase the heart rate, endothelial dysfunction. This is the most important element that causes the damage by the nicotine in the cardiovascular system, and then ultimately there will be a development of atherosclerosis. So, if we would like to have a look on the carbon monoxide decreases the availability of the oxygen, because the carbon monoxide has more affinity to the hemoglobin rather than the oxygen. So there will be decrease in the myocardial oxygen uptake, and ultimately there will be a myocardial infarctions, and ultimately will be cardiovascular dysfunctions. And of course here, if we just look into the cardiovascular risk reduction by the quitting, so this is the benefits which we are going to get because of the quitting. So it depends on the dose, how many cigarettes the patient smokes. It depends on the durations, how many years. And it depends on age. If the patient is elderly, so definitely the comorbidities will be much more highlighted. And even the other comorbidities like hypertension, like cardiovascular disease, or even COPD. So the quitting before the age of 4 years reduced the risk of tobacco-attributed death by 90%, which is really huge. And nearly half of the excess of cardiovascular risk is eliminated by 2 years of quitting. As you can see here in the graph, within 2 to 4 years, about half of the risk has been deducted. So smokers with congestive heart failure, if they get the smoking cessation, or decrease the mortality by 30% in the first year of cessation, and smokers who quit after myocardial infarctions, they have 36% reductions in the cardiovascular mortality over 2 years compared with the non-smokers, with the continuing smokers. And quitting after CABG or PCI improved the survival and reduced the risk of additional procedures and the risk of the death compared with the individuals. And in fact, there is many trials to support this kind of statements. So this was the first part. This is the most important part of my presentation. So what is next? What is our role? What is our responsibility towards our patients? So definitely, we have to know that now they consider tobacco smoking or cigarette smoking like any other disease, like any other chronic disease. Why? Because it's a long-term duration. Most of the smokers, they smoke for decades. And moreover, it has a period of relapses and remissions. So the patient goes into relapse, try to quit, and then he goes back again. And he has acute bronchitis back and forth. And it requires an ongoing rather than acute. So let's understand what is the cycle of nicotine dependence. So as you see, when the smoker smokes cigarettes, there will be a release of nicotine. And nicotine will be attached to the nicotine receptors, and there will be a chemical reactions for which there will be a release of certain dopamine. And this dopamine will give the pleasure and the happiness and the focus and the concentration of the patient who smokes. And then, because of the lack of the nicotine, there will be a drop of dopamine, and the patient will be subjected to the withdrawal symptoms of smoking. So the tolerance decrease sensitivity by the time those who are smokes 1 cigarette or 1 pack, definitely after 10 years, they need 1.5 pack, because the affinity of those receptors will get reduced by time. But again, the smokers will try to accommodate this by inhaling more and keeping the smokes within his lungs for a longer period of time in order to saturate those receptors in the brain. So we have to remember that there is certain withdrawal symptoms, which is usually the very devastating, experience of most of the smokers, and it's considered to be one of the cause for failure of treatment if you don't address it. So those patients, if they quit smoking without any help, definitely they will have irritability, anxiety, restlessness, they have increased or decreased appetite, they have insomnia, and they will become very agitated. So this is very important. Here, I would like to share with you one of the initiatives that we have done it in my hospital, the International Medical Center. So we thought that we have to take it as a corporate social responsibility. It should be not a missed opportunity for any patients who come into the hospital and he's a smoker and seeking some other help from any healthcare providers. So we have modified our health system to identify. So, do you smoke? Yes, no, or ex-smoker? This is a question which has been implemented in the health system, and it will be counted as the 5th or the 6th vital signs. So the nurse will take the vital sign, and the 6th question will be asked, do you smoke? Yes, no, or ex-smoker? If he's a smoker, the system will be alert with this, and the patient will be alert to all the doctors across the board, regardless what is his specialty, even if he's orthopedic or dermatologist or whatever. So he will be flagged with this. So he has no choice but to provide the patient with a 3 seconds smoking cessation brief advice. And we have trained all our doctors with this. So this will be an opportunity to convert the patient from the pre-contemplation state to the contemplation state, and then he will be very appropriately managed. And then the patient will have, and the doctor will have to refer the patient to the smoking cessation, or he will have to say that the patient is refused. So what happens? The patient will be counted again and again, and the other visit will be repeated till the patients get the concept that he has to go for the smoking cessation. And we capture a lot of patients by this initiative, and it's become very rewarding for all of us to have a healthy community within our organization. So, it's again very important to identify whether your smoker is addictive or not addictive and what type of addictions. So this is a brief Fagerstrom, Karl Fagerstrom is a French scientist who developed this question. How soon after waking do you smoke your first cigarette? Less than 5 minutes, this is 3 points. 5 to 30 minutes, this is 2 points. 31 to 60 minutes, this is 1 point. The other question, which has been validated and with a high sensitivity and specificity, is how many cigarettes do you smoke each day? More than 30 cigarettes, 3 points. 21 to 30 cigarettes, 2 points. And 11 to 20 cigarettes, 1 point. And then comes the scoring keys. So if you have a patient who scored 5 to 6 points, he is a heavy nicotine dependence. And what does it mean? That means that you have to use a combination of medications. You have to use the medication for a longer period of time, and you have to make sure that the patient gets a multidisciplinary team approach, psychologist, educator, and everybody should share with you this kind of patient because he's a very difficult patient to manage and a very fragile patient to get into relapses. But if the patient has 3 to 4 points, this is moderate, and if the patient has 2 points, this is light nicotine dependence, and they can go cold turkey. Cold turkey means by their will they can manage without any medications. So, I have time? Okay. So there is 5 A's and 5 R's. So those you patients who have been convinced to be a quitter and they are getting to you to quit smoking, ask the 5. Ask about the smoking. How many cigarettes and how long the duration. Advise every smoking to stop smoking. And they have identified the question. If you say to your patient, if you quit smoking or smoking quitting is the best thing that you can do for your health, this is a very validated question, and this will convert the patient to an active patient to perceive what you have said. Assess the readiness of the quit every visit and to see if the patient is ready so you can start. If not ready, you can ask him to come again. Assist the smoker to stop smoking and arrange for follow-up and monitor. But if the patient is reluctant and he's resistant, so go for the 4, 5 R's. Relevance, tailor your advice and discussion to each patient. Now we are in the era of medicine where we talk one size is not fit for all. We should customize our management plan based on the patient profile. Each patient with you, he should be tailored according to his need, the medical, the psychological, the medical, the social, the psychological needs has to be addressed. So then outline the risk of the continuous smoking, tell him about the bad consequences, and reward. Outline the benefits of the quitting smoking, and then the roadblock, identify the barriers. Each one of the smokers, they have certain barriers, and you have to highlight it and you have to address it. Otherwise, you will have misunderstanding why the patient is not getting into the quitting stage. Repeat it. Just keep on repeating these 5 A's every encounter with patient to convert the patient into a patient who really decisive. So let's go quickly about the pharmacotherapies. In fact, we have many medications. In 1970, they have introduced the behavior modifications, which works very well, but actually it wasn't enough. But later on in 1980s, we started having the nicotine replacement therapy, where we have now the gums, we have the patches, we have the lysogens, we have the sprays, and we have a lot of devices that deliver nicotines. Okay? So what is the benefits of this nicotine? We are giving the patient the same nicotine in the cigarette without the toxic substances. And we go into certain, the one which is more available here is a nicotine patch. We have 21 milligrams, we have 14, and we have 7 milligrams. So if the patient is severely addicted, so you go with a higher dose for 21 milligrams for 2 or 3 weeks, and then after that you go for 14 for another 2 or 3 weeks, and then 7 milligrams for another 2 or 3 weeks. And always remember, please, medications alone never work. So the combinations of behavior modifications, psychosocial support, and then come the medications. So 3 elements: behavior modification, psychosocial support, and medications. It will work.
Will you conclude, please?
Yes. So the second medication is bupropion. This is an antidepressant. It works very well. And usually in difficult cases, we combine the nicotine replacement therapy with bupropion and give us a very good result. But the most advanced one, which has been released in the market in 2009 or 2006 in the States, 2009 in Saudi Arabia, is the Champix, which works in the brain. It blocks the nicotinic receptors and releases certain amount of dopamine, so it prevents. Even if the patient smokes during the therapy of Champix, he doesn't have the same flavor which he got to use with a regular cigarette. So these are the medications. So there is a side effect. Please go read about it and look into it. And if you need any help, I'll be very pleased to provide you with all the details because of the short of time. So in 2011, I've been privileged to be one of the co-authors for the smoking cessation in the Middle East and Africa, and we have published a very nice recommendations. So if you would like to go through it, you will have all the details, how to manage the regular patient, the difficult patients, and all kind of dilemmas and frequently asked questions in this. So to conclude, ladies and gentlemen, cigarette smoking is a powerful modifiable risk, the cardiovascular risk factors, so it's a modifiable. Still, we can do something good for our patients with a minimal efforts and a cost-effective measures. And this smoking cigarettes contribute significantly to cardiovascular mortality and morbidity and impact all the phases of atherosclerosis from endothelial dysfunction to the acute clinical event. So those patients, they get into endothelial dysfunctions and then they will be a victim for acute events from time to time and exert an hypertensive effect mainly through the stimulations of the sympathetic nervous system. And this is the conclusion which I would like to highlight it to you. And now we have the clear association by evidence that there is a very strong association between the smoking and hypertension. The role of us as a provider is to give a smoking cessation brief advice, which will take only 3 seconds. Okay, 30 seconds, but it has a very good impact of our patients, and we have to refer patient to the smoking cessation clinic for psychosocial support, for behavior modifications, and pharmacological therapy. With this, I would like to thank you for your listening, and I wish you a very successful management of our hypertensive patients who are a smoker. Thank you very much.
Thank you, Dr. Ashraf. Thank you. I would like to invite Dr. Omar Ayub. Dr. Omar is a neurologist at King Abdulaziz University, and he's going to talk to us about hypertension and central nervous system. Please, Dr. Omar.
Assalamu alaikum wa rahmatullah. First, I'd like to thank the organizing committee for the invitation, and I thank everybody who stayed late in the conference. It's 4 o'clock, and you should be at home by now, but thank you for staying to the lectures. I was giving the topic to speak about hypertension and its association with CNS disorders. And I think if I spend 20 minutes in that topic, it's not going to give any fair neither to the topic itself and neither to you. I would like to be very concise. I have chosen one of the topics of neurological disorders and hypertension, which is important, and I took the controversial part of the acute stroke and hypertension rather than long-term management of hypertension and stroke. So all what you will see are the data for patients who are presenting with acute stroke, and what are we going to do with their treatment. Shall we stop it? Shall we continue treatment? And what are the medications that we should start? How are we going to tackle the exact numbers, if there are any? But we'll see how this will go. So the epidemiology, you're all aware of, the stroke affects about 15 million people around the globe. It used to be the third leading cause of disability, but recently it has been upgraded to the second leading cause of death. It is the leading cause of disability. It used to be the third, and now it's the second leading cause of death after cardiovascular disorders. Blood pressure or high BP is also one of the important and leading modifiable risk factors that we need to target on the long term in patients with stroke. About 75 to 75% in some papers of patients who are presenting with stroke have high blood pressure. Some of them may have low blood pressure, but the majority, they have high. We have the concept that blood pressure falls in the acute period. So if someone presents with high blood pressure during the acute stroke, in the, let's say, 180, 170, it will fall spontaneously. But should we wait for that fall? Should we wait 1 day, 2 days, 3 days, 5 days, 1 week, 2 weeks? We actually don't know until now. The most important concept in the whole treatment of acute stroke that you need to understand, and I think most of the trials have been swayed by that concept. All what we do in acute stroke in terms of acute thrombolysis, thrombectomy, it all depends on the concept of the core and the penumbra. So you have to understand that very well. One of the things that I need also to share with you is that the treatment of acute stroke in terms of thrombolysis has changed significantly over the years. We used to think of acute stroke to be treated by thrombolytic within 3 hours. That has changed over the years to be 4.5 hours. In the recent World Congress of Stroke, they have published or released the information on the trial, extended trial, where we can now thrombolyze patients up to 9 hours. So that is going to come. It is not a guideline yet, but it will change. The concept of time treatment has already vanished from the literature. We already now depend on tissue-based treatment. So patients who have viable tissue will be treated with either thrombolysis as IV or thrombectomies. And the same thing applies to hypertension. So hypertension, you can see the differences in my talk about the outcomes in many of the subclasses of antihypertensives. It's mainly depending on that penumbra. So if you have someone who is presenting with, let's say, an MCA stroke, the first circle, which is the dark one, it's already gone. So someone who presents with right-sided weakness and aphasia, okay, we may see the manifestations because of the stunned tissue of the penumbra. So the amount of potential stroke, that is the penumbra, is making the patient symptomatic. But what is the final outcome of the patient, whether he is going to go into complete hemiplegia or complete hemiplegia and aphasia with visual field loss, is depending if you can save that penumbra and leave him with a small core. So if you maintain proper perfusion of the brain, either by maintaining high blood pressure during the acute period or opening that vessel, this will ensure that those areas who are still not dead yet will be saved. On the right-hand side of the figure, you can see that we have different things or different tests that we do to say, oh, this tissue is in the penumbra phase, or this tissue is already dead. The most important of which is CT perfusion. And that's what we usually do in our university hospital. If someone presents within the acute period, we do straight CT angiogram, and then we do CT perfusion. If that patient, no matter what is the time factor of his presentation, will be treated according to the CT perfusion if he had an area to save. And the same thing happened here. You can start up with a red area that is very small at the beginning, with a green area that you could save if you treat the patient appropriately by thrombolytic, and also if you treat the blood pressure appropriately. That area will get bigger and bigger and bigger if you don't do all what we can do to save the brain tissue. That's the image of the perfusion pressure. All what it says is that we have cerebral volume and transit time or flow. So if you have a prolongation in the flow in certain areas of the brain with preserved volume, that means that area is not dead yet. But if you have high volume with high or impaired cerebral blood flow, that means it's a dead tissue. And that's the way that we look at CT perfusion to know that these are the areas that we need to save. It's been well known that there is a U-shape. If you want to remember anything from my lecture with hypertension and acute stroke, there is a U-shape relationship between acute stroke and hypertension. So if you lower the blood pressure extensively, to a very low period, low levels, which is, it's around less than 140. And if it is more than 160 or 180, this is detrimental to the brain during the acute period. So your plan is to keep that blood pressure in the acute phase within 140 to 60. And that's the usual figure I always tell my residents. Keep it between 140 and 160. This is safe. Forget everything else, despite the guidelines. So from the acute stroke trials, we know that the pulse pressure, the variability in the systolic blood pressure, the MAP, all of them, they can have poor functional outcome in association with a stroke. We have multiple reasons why those patients with acute stroke might have a hypertensive episode. Namely, they might have infection, they might have hypertension, they might have pain, stress. So there are too many things that are a big player to the elevation of hypertension. The autoregulation of the brain is still impaired during the acute stroke, and that will make the perfusion to the brain dependent mainly on your MAP, or the cerebral perfusion is dependent on the MAP. So if you have rapid elevation or rapid deterioration of blood pressure during the acute phase, that will be also detrimental. So what were the trials that looked at blood pressure? Multiple and multiple and multiple. I'm not going to go over them in details. All what I was going to say is that, let's say one of the earliest trials was the CATIS, which is a Chinese trial, involved about 4,000 people when they give different kinds of medications. They could achieve the lowering of the blood pressure, but at the end, when they looked at the primary outcome, which is the modified Rankin scale more than or equal 3 at 14 days of discharge, the results were neutral. So there was no benefit of reducing the blood pressure during the acute stroke. They looked at the clonidine. It was a small trial, never have done it in the longer trials, and we can't have any suggestion that we can use clonidine during the acute period of the stroke. What about ACE inhibitors? Initially, they looked at 3 small trials. They were feasibility trials looking at hypertension and acute stroke. They figured that probably there is an improvement in the NIH stroke scale, but overall there was no difference in the outcome as measured by the modified Rankin scale or even the scores in the NIH. They said, okay, let's do another trial, which is the CHIPS trial, 179 patients with either ischemic or hemorrhagic stroke within 36 hours and with hypertension. They were given either oral treatment or IV, depending if you can ingest medications or not. And they were escalating the medications according to the response. And eventually what they said is that lisinopril that they use in the CHIPS, they reduced the blood pressure appropriately, but overall there was no differences in the functional outcome. Then came the other trial, which is the pill fast. The same thing. They randomized people within 3 hours, and they looked at lisinopril versus placebo. They could also decrease the blood pressure. That trial also was negative. Then they shift gears to the ARBs, or the ARA, or the angiotensin receptor antagonist, and they have looked at it in multiple trials, which is the AXIS, the subgroup of the PROFESS, and the SCAST as well. What they have found is that probably the ARBs in the acute phase of the stroke is not only neutral and can be actually detrimental to the use during the acute period. Nobody knows exactly why does this happen, but we don't have good outcomes with the ARBs. Beta blockers, it has multiple. There had been also multiple opinions about beta blocker use during the acute phase. Some of them they said, please use it. Some of them said, don't use it. But overall, still, the outcomes in most of the trials during the acute period are neutral. There is no effect on overall outcome. Calcium channel blockers had been assessed at the INWEST, where they had looked at to use calcium channel blocker in acute stroke within the first 24 hours. They were randomized to IV nimodipine as an infusion or an IV, either to 1 milligram or 2 milligrams for 5 days, and then 120 milligram orally for a continuation of 21 days. They stopped the recruitment because of the unfavorable outcome, which was measured also by the Barthel Index, which is one of the measures for outcome in patients with acute stroke. Again, calcium channel blocker wasn't really very attractive in the use. They have conducted a further trial with the use of oral nimodipine, and that trial was stopped because there was a publication of a Cochrane review of 7,665 patients from 29 trials, which showed no treatment effect on functional outcome or death if you use calcium channel antagonists. Diuretic has the same thing. They looked at magnesium during the period of ultra-early timing of acute stroke or during the acute stroke in the hospitalization, and it was also 50-50 outcome. Same thing with nitric oxide. So after looking at all of these trials and all of these data on multiple classes of antihypertensive medications during an acute stroke, we eventually say we don't know. That's, I think, the better term of saying that we have done too many trials and we couldn't reach a proper outcome that we have thought that they are going to be effective. I think part of the reason is that we are collecting all types of strokes together. And I think because of the differences in the timing that we are giving the medications, some of them given within the first 6 hours, some of them given in the first 24 hours, some of them given within the first 3 days, there was discrepancy in all of these trials. We cannot really lump all strokes together. There is major differences between the pathophysiology of acute stroke in a large vessel disease versus small vessel disease, and you can't also lump these together. I think the pathophysiology and also the mechanism of the stroke in both are different. Because if you are going to look at only large vessel disease, I always say, please don't drop blood pressure in large vessel disease. If someone has, let's say, ICA stenosis or ICA block or MCA stroke, I keep blood pressure high, just leave it, unless I'm going to thrombolyze. And that's also being translated into the guidelines. So the current guideline says, during the acute period, which may extend up to a week or 2 weeks, don't drop blood pressure significantly. Leave it, even if it is scary, which is 220 or over 120. Leave that blood pressure. Don't treat it unless there is end organ damage, like acute injury, kidney injury, if there is any aortic dissection, cardiac ischemia, encephalopathy, or pulmonary edema. That is a totally different game plan. But for someone who has only acute stroke, don't drop blood pressure. And if you want to drop blood pressure because of the nurses is bugging you, drop it by maximum of 20% during the acute period, and that's about it. Should we keep the antihypertensives or we should not? I think it's up to you. It's been also controversial in the literature. When someone comes during the acute phase and they had been on medications, should we leave it? Should we leave the antihypertensive or should we stop it? I think the jury is not out, and I think do whatever you want as long as you are keeping the blood pressure within your limits. But if you are going to treat those patients, we have standard guidelines. So for the TPA, for the thrombolysis, if you are going to give that patient thrombolysis, blood pressure has to be less than 185 over 110. And that's a guideline. It's been agreed upon. Unfortunately, to tell you the truth, that recommendation was based on expert opinion. It wasn't actually on a randomized controlled trials, but it was working beautifully in most of the IV thrombolytic trials and also for the thrombectomy trials. After you treat those patients, then your digits for the blood pressure has to be lower. So this is one of the few things in acute stroke that is agreed upon, is that if you are going to treat patients with thrombolysis, keep blood pressure less than 180 over 105. They looked at the SITS registry, which is one of the largest registries in the globe, and they have looked at those patients who had been treated with thrombolysis and then with high blood pressure, and they said that higher blood pressure during thrombolysis that does not follow the guideline, it was associated with poor outcome and also increased mortality. So that was a support that we should treat hypertension during the either pre-thrombolysis or post-thrombolysis. Otherwise, leave blood pressure rise wherever you want it. And this is the latest guideline. It was updated in 2018. It is summarizing exactly of what I was saying in the last trials. One of the things I need you just to remember, these are the newest trials, which is the 5 trials of the thrombectomy that we have that have changed the treatment of acute strokes and large vessel occlusions. I have too many other slides. I think I'm going to skip them for the sake of time. Do I have time? 1 minute? No, خلاص, enough. Because I have few slides about treatment with large vessel disease, also bilateral carotid stenosis. I have treatment of ICH, but I think I'm going to skip that and leave it for further questions if you have. Thank you very much.
Thank you, Dr. Omar.
We have the best topic at the end of our session, so the stroke and hypertension. And now I am honored to introduce my colleague, Dr. Faiza Gari. She is a professor of medicine and endocrinology at King Abdulaziz University in Jeddah. And she is known to our community as very interested in treatment of diabetes. Please, Dr. Gari.
بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه وسلم أجمعين. I'm sure that everybody tired and get fed up and he wants to go home, especially me, from the morning. I will just try to make it easier, practical, in case scenario, rather than just a lot of data and a lot of research and like this. Try to make it so simple. Yes, please. Okay, so we know everybody talk about irhab. So what our irhab in medicine? So the most important irhab in our medicine actually is diabetes and hypertension. We start with like this. So why we said like this? Because we know that hypertension is usually associated in diabetes and is twice commoner in diabetic patients. The new onset diabetic patients, they have 2.5 times more commoner in hypertension. Around 40% of patients are pre-diabetic with impaired glucose tolerance test, they are hypertensive. 40% to 50% diabetic patients, usually they have a hypertension. Only, unfortunately, only quarter of those patients being controlled. We know if we have we have hypertension, diabetes, and etc., that increasing the cardiovascular risk. Usually diabetes lead to hypertension, hypertension lead to diabetes. If diabetes associated with hypertension, will increase all the other comorbidity from neuropathy, from nephropathy, from retinopathy, stroke, which is most important thing as mentioned by Dr. Omar, coronary heart disease, and of course mortality. So that's 40 to 80% of diabetic patients is usually they have hypertension. If they are diabetic, it's more likely twice commoner, twofold increase in the hypertension as being demonstrated in this slide. The problem of hypertension in diabetes that is mainly associated with systolic hypertension. Problem of systolic hypertension is one of the important cardiovascular risk factors, and systolic hypertension is sometimes very difficult to control. The thing that the patients, if they are diabetic and they have hypertension, they get depressed. So the questions of compliance, it will be poor, and they don't want to take medication. One of important issue that I put it in yellow, that clinicians inertia. What is this clinical inertia? That we focus only on diabetes, and we don't look to the hypertension when patients come to our office, or just we underestimate it. Yeah, maybe next visit I will see the hypertension. I am scared, I am whatever. So we don't treat the patients with hypertension, just we concentrate on diabetes, and that will cause a problem in the future. Of course, there's a lot of studies, but the meta-analysis showed if we manage to reduce the blood pressures in diabetic patients, we manage to reduce the stroke, we manage to reduce the total mortality, we manage to reduce the cardiovascular events. So what is hypertension in 2018, as you mentioned? The most important thing, 4 important things. First, how to diagnose hypertension in diabetic patients when they come to the office. Before that, we measure the blood pressures in the office. But now we don't say like this. We said either we do ambulatory blood pressures measurement, or the best way that patients, they measure blood pressures by this automated blood pressures measurement, and we can take reading, because by this way, we avoid the white coat hypertension. So that's one important message that we have to keep it in our mind. Second, what targeting blood pressures we wanted in our patient, especially diabetic patient. So we take this scenario. What is going on now? Yes. So what's the result of blood pressures we wanted in our patient? So we start with simple scenario. We'll not go for details. So we have an old patient. Mr. Ali is more than 76. He's had myocardial infarctions. He's been hypertensive for quite long time. His blood pressure is around 135/80. He's taking a lot of medications for controlling his blood pressures. His hemoglobin A1C is not bad. It's around 6.5. His cholesterol is being to the target, and we measure his blood pressures at the office, and we found it 135/80. Are we happy with these blood pressures? Yes or no? خلينا بس نصحصح شوية. Yes or no? So he's a diabetic, he has a cardiovascular risk. So usually, we go to the next. In those patients with a high risk, the patients, high-risk patients, they have already a cardiovascular problem, they are diabetic, we want to be strongly control the blood pressures. So our aim to reduce the blood pressures to 20 or less than 20 systolic and diastolic less than 80. This is a high-risk patient. And of course, if they are not a high-risk patient, we can accept more higher blood pressures, as you heard through the day. So in high-risk patients, in diabetic patients, we want our blood pressures to be strongly controlled, better to be less than 120 systolic and 180 diastolic. So for those patients, especially high-risk patients, especially if they age more than 50, if the systolic blood pressure is more than 130, try to reduce the blood pressures to 120. Of course, if when we do this one, is not happening without a price. So the price for those patients that they will be, this is an intensive management for those patients, and usually we advise those patients to have a blood pressure monitor at home so they measure it, and when we give them this many medication. So the guidelines according to this SPRINT study, which is a large and huge study, more than around 10,000 population, so they recommend that we have to do this intensive glucose targeting for the patient, intensive blood pressure monitoring for high-risk patients, especially if they have a cardiovascular problem, clinical or subclinical, and especially in diabetic patients, or even if they have a chronic kidney disease, either diabetic or non-diabetic, or if we estimate the cardiovascular risk factors in 10 years' time is more than or equal 15%, or if they are old. So this is the patients that we want an intensive management of blood pressures. Of course, by giving a lot of medications, what happens to the patient? They can have hypotension, they can have a renal deterioration, they can have a potassium abnormalities. So you have to spend time with patients telling them what is the benefit of intensive controlling the blood pressure, as well the other risk, and take the consent. Explain to your patients about intensive management for the hypertension. So according to there is how intensive therapy we want it for our patients. Of course, there is limitations to or no evidence, but we have some evidence, especially in diabetic. I put it in the green. According to a core study, that if intensified hypertension management in our patient is not without a risk, and some of patients in this accord study they die, but still the benefit is more. And there is, of course, is contraindicated in certain type of patients, but will concentrate in diabetic patients. So the message from this patients or from this scenario, that you have to choose your patient, especially diabetic patient, intensify your therapy, and we want the blood pressures to be controlled around less than 120/80. Of course, modified or controlled by automated blood pressures in the patients at home. So this is the first message. Second message, what types of medicine is better for those patients? Of course, for diabetic patient, ERB or AC inhibitor, but just if the patient he's taking, usually we don't use single medications, we use more than medicine. So if the patient is on thiazide diuretic, most of the medications combination therapy. We take this scenario, so Faisal is a 53 years old patient, he's a hypertensive, he's taking medication for a couple of years. He managed to lose some weight. His hemoglobin A1C is around 6.8, and his blood pressures when he came is 130/20. But important thing that he's taking as medications, he's taking hydrochlorothiazide. Are we happy with this blood pressures, and are we happy with the medications? Any بس شوية عشان مندوخ ونصحصح على النهاية. Okay, so we are happy about his blood pressures, lastly, 130/84. But what about hydrochlorothiazide? So now the long-acting thiazide diuretics like indamamide, اللي هو الناتريلكس, or short-acting hydrochlorothiazide. The best, of course, is the long-acting indamamide. We know that the thiazide, whatever thiazide, is a good for patients. There's a lot of studies prove that it improves the cardiovascular mortality, improves the cerebrovascular accidents, improve the heart failure, and all-cause mortality. Seeing here that you're seeing by the long-acting, which is the gray one, is better controlling the blood pressures, and more important is reducing in cardiovascular mortality than the short-acting. So that's we try to shift the patients to the long-acting thiazide, aiming to reaching to in comparing to the short-acting. The third message or third clinical scenario that in any patients, especially diabetic patients, we talk about diabetic patients, when they come to our office, we try to use single pills combination, that one pill containing more than one medicine. We don't want to try to give patients. This is usually maybe in private hospital, we use single pill combination. Unfortunately, maybe in military hospital or National Guard hospital, they still they like the titration of medicine. But we'll see. So Mr. Muhammad is a 59-year-old patient. He's a diabetic. And he is, for the last 3 years, his blood pressure is around 146/92. His blood sugars is not bad. Hemoglobin A1C is around 6.8. His LDL is 3.9. He's taking a lot of medicine, but he's not a good compliance. And he asked you, what about the single bed treatment? So what antihypertensive would consider in these patients? Remind you again, diabetic, hypertensive for quite few years, and he is hypercholesteremia. Of course, any patients, the first-line recommendations for those patients, especially in diabetic, we want it tightly controlled. So we have this group of medicine from thiazide, diuretics, long-acting or short-acting, ACE inhibitor, ARB, calcium channel blockers, and beta blocker. So usually we combine therapy. And of course, in patients diabetic, we try to choose ACE inhibitor and ARB in that combinations, and we have a lot of combination. And that's an easy initial therapy. We don't want to have to wait and start one therapy and then another therapy, especially if the systolic blood pressure is more than 20 and diastolic more than 10 when he initially presented. But we try to avoid the beta blockers in patients above the age of 60. So single pill combination is the best for our patients, either in 2017 or 2018. So long-acting thiazide, like diuretics, preferred than short-acting thiazide. Beta blockers is not advisable for patients above the age of 60. The best, of course, especially for diabetic patients, angiotensin receptor inhibitor and calcium AC inhibitors. That's the best combination for those patients, and recommended single pill therapy in those patients, especially with diuretic. And we have a lot of combinations in the market. So, of course, AC and ARB is the best. We know why it is the best. Mentioned it how many times and during the day. Well tolerated. This side effect, reducing, most important, is reducing cardiovascular mortality and morbidity. And usually we have to be careful in certain types of patients, like patients with bilateral renal stenosis or severe renal impairment, or we have to watch the potassium very carefully. Some patients, they suffer from cough with AC inhibitor and angioedema, but it's a beautiful drug, and especially with combination. So the advantage of single pill therapy, combination therapy, that is associated with better compliance for our patients. The regimen featuring initial prescription of single pill combinations lead to better blood pressure control. Initial combination therapy, we have to keep in our mind to reduce the cardiovascular events than monotherapy. So there is two main great studies, which is mentioning that single pill combination, especially if we combine ACE inhibitor or ARB with calcium channel blockers plus or minus diuretic, is proved to be much better than just giving the patients many medicine. And this is study being published in New England Medical Journal, HOPE-3, as well another study which is as well published in a New England Medical Journal. So we'll just skip this slide. You can choose whatever if you have patients less than older or younger than patients with than 55, especially in diabetic patients, keeping in your mind that AC and ARB is one of important things that you have to put it in your choose of your medicine, especially single drug combination. So lastly, take-home message. 4 important take-home message. 1, depends on ambulatory blood pressure measurement for your patient. That is important. Don't rely on what you measure the blood pressures in the clinic. Second, if you can choose the long-acting diuretic for patients, is better for our patients, especially diabetic patients, and more control and more cardiovascular protection. Third important thing, that what targeting blood pressures we needed in diabetic patients. We wanted intensive control of blood pressure, aiming that prevent cardiovascular mortality as well renal deterioration. And fourth important thing, try to choose single pill therapy, keeping in your mind in these combinations in diabetic that containing ACE inhibitor and ARB. And I think that's finishing your day. Shukran.
Thank you, Dr. Faiza, especially because you finished on time. I think we have now time for discussion. Can I ask the speaker to join us? Okay.
Okay, maybe I will start with a short question to Dr. Ashraf, and then we'll take the question from here. Yes, Dr. Ashraf, since we know that currently lots of our teenagers are either smoking or asilo, do you see lots of early adulthood hypertensive in the family medicine clinics?
Thank you for the question, because as I have demonstrated in my presentation, there is a strong association between hypertension, between smoking cigarettes and tobacco with hypertension. Although it is a long process, it will take many, many years to take place, but still, this could be one of the explanations why we have this kind of problem, hypertension early stage and early adulthood. This could be, but there is no trials so far to demonstrate this, so this could be just only a hypothesis at this stage.
Combination of ACE inhibitor and ARB together, especially in the treatment of diabetic nephropathy. Is there a place for combination these the same family drugs together in the treatment of diabetic nephropathy? I heard from one nephrologist before many years ago that he can use for the treatment of diabetic nephropathy in diabetic patients.
Actually, I didn't come across that we have to combine it because it's quite dangerous. That's the hyperkalemia. But you choose one of them. Combination per se, no. Just use either ARP or C inhibitor, but don't put two medications together because there's a big danger of hyperkalemia in those patients. It's not combined, no.
But the other question, is there any figure number of creatinine level? For example, before we knew that up to 3 milligram of creatinine or above, we have to withhold, we have to stop the AC inhibitor or the ARB. Is there a figure like this still or no?
May I comment?
Serum creatinine of 3 and above.
ممكن دكتورة هي بتاعت nephrologist, and tomorrow I will give the hypertension and the kidney. So if you will attend tomorrow morning, inshallah, first lecture, but in simple, that's why I want you to attend tomorrow. But in simple, we should not combine ACE and ARBs together. even in diabetic nephropathy. If we have a patient who's on multiple antihypertensive medications.
Okay. Could you please repeat? Because he couldn't hear. He couldn't hear the answer. If you would repeat.
Yes. In short, we should not combine ACE and ARBs together in diabetic nephropathy, especially if the patient is in advanced chronic kidney disease, and especially if the patient is in a stage 4 or 5. We should not combine because of the side effects. I hope tomorrow you will attend the kidney and hypertension.
I will ask one question to Dr. Amir. Yeah, unfortunately, that what we notice that the doctors, the models, and when just they go outside the hospital and see smoking, they are smoking, and especially, I can put it, cardiologist. So how can, really, this is what I notice. Many cardiologists, I can see them by my eyes, and they go outside and they smoke. And how patient we can convince them to smoke? Second, we notice a lot of ladies start shisha smoking. What's about shisha in comparing to cigarettes?
Yes, okay. Thank you. Very interesting questions, in fact. And when we talk about us as a healthcare providers, we are not presenting ourselves professionally, and we are not the role model for our patients. While we are wearing the white coat, we have a cigarette in our hands, and this is the feet. You know, the purpose of being the vehicles of healing in the healing process of patients' journey. So this will highlight the initiative that we had in IMC. We have sponsored all smokers in International Medical Center to be covered free of charge by the hospital administrations. So each one of them costs us about $2,400 to take him all through a journey of almost 2 to 3 months. And now Dr. Al-Hamid can echo what I'm saying, that we have those who were smoking for 35 years, 3 packs. Now we have the first batch who are free of smoking for the past 6 months. And this has been impacted very well on the productivity and the performance of our colleagues in different sectors. Not only this, but even the morale. They are becoming more energetic, and they are becoming a role model for the others to understand that smoking cessation is not a big deal. So changing the culture within organizations to adapt all the important elements to secure the wellness rather than illness. This is very important to change the workplace to work for that end. This is one question. Yeah, the ladies who smoke shisha. Shisha is almost 60 to 100 cigarettes. Okay, so imagine the bad effect is 60 to 100. It depends. One shisha, yes. And it's documented, and you can go and see all the reference saying this. But in spite of this, we have a misconceptions and the mindset of our people in the community. Say, when you ask them, do you smoke? They said, no, I don't smoke, but I'm ashayish. As if the shisha is not smoking. No, there is a lot of evidence, and there is a lot of trials that, and even, you know, the shisha, there is a water. And the water humidify the smokes and make it more absorbable by the blood vessels and even the bronchus. So the harm is humongous.
One simple question, please, because we have to
I'm Dr. Kamal. Yes. I'm asking Dr. Sami for some...
Dr. Sami is not here. Unfortunately, he left. So probably if you are here tomorrow, you can ask Dr. Sami, Professor Sami Sanjad, his questions.
Okay, thank you.
Okay, yes, sure. Sure.
I'm asking about the syndrome with hypokalemic hypertension in pregnancy. Hypokalemic hypertension with pregnancy, Geller syndrome. How to differentiate between hypokalemic hypertension as Geller syndrome or preeclampsia, and should treat hypokalemia alone and hypertension alone, or treat it as Geller syndrome? We start amiloride, as he said, and treat hypertension otherwise. Also for management of Liddle syndrome and AME. For AME, we give amiloride, and for Liddle syndrome, we give spironolactone. Clinically, same clinically and biochemically, both hypokalemic hypertension with alkalosis. For clinical management, start which is which. We can combine or thank you.
Please, Dr. Saleh.
Thank you very much. Actually, you can differentiate it so easily. Preeclampsia are, with a certain criteria. And you can just see whether that hypertension started during the pregnancy or that lady is having hypertension before. This is one. Two. Hypokalemic hypertension pregnancy can be either this or it's associated with preeclampsia itself. It's very, very simple, actually. What you need to do is chloride in the urine. If the chloride in the urine is very high, this is monogenic syndrome. If the chloride in the urine is low or normal, this is a preeclampsia. It's very simple test. Any lab can do it. What's your next question? I did not get you.
The management between AME and Liddle syndrome. The management is different. Amiloride, spironolactone for Liddle, and amiloride and carbidoxolone for others.
Yeah, because that depends on what mechanism. The AME is in the, convoluted tubule, and the Liddle syndrome in the thick ascending limb of Henle. That actually affects sodium 2 chloride potassium channel. So if you give amiloride, you will block that sodium 2 chloride potassium channel, and that will lead to improvement of the hypertension. That mechanism is not involved in the convoluted tubule. That's why spironolactone is a totally different mechanism. So you are talking about two different mechanisms, not one mechanism. So it's, again, there is simple tests, not only the genetic tests, you can perform through doing tubular function studies by doing, for example, hypotonic diuresis tests. You can, know which one is which, and you can block the mechanism involved, and you can treat the hypertension in complex. Usually in adults, if the hypertension is not well controlled, usually you will add spironolactone. And that by itself is a therapeutic test. So if you add it and the hypertension does not really improve, then you have to think again, and you can go for hypotonic diuresis test, or you can go to amiloride and you treat it. Thank you.
At the end of this busy day, I would like to thank the auditorium for their patience, and I would like to thank the speaker, and Dr. Nawal will give them the certificate.
Very simple, concise, important. Thank you very much.